बिस्मिल्लाहिर्रहमानिर्रहीम रब्बी इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली अल्लाहुम्मा इन्नी अस्अलुका इल्मन नाफ़िअन रिज़्क़न तय्यिबन अमलन मुतक़ब्बला शिफ़ाअ मिन कुल्ली दा. Today I am going to discuss about the surgical management of the ectopic pregnancy. This is part 2 of the ectopic pregnancy and my second lecture for the surgical management. Laproscopy, hemodynamically stable and location of the ectopic pregnancy, experience of the surgeon, size less than 6 centimeter. They are candidate for the surgical management. Laparotomy, hemodynamically unstable, ruptured and size more than 6 centimeter. So laparoscopy we always prefer for the patients who are stable hemodynamically, vital signs stable, and we know the location of the ectopic pregnancy. Experience of the surgeon is up to the mark, and the size of the ectopic pregnancy, it is less than 6 centimeter. But laparotomy we always do for the patients who are hemodynamically unstable and ectopic pregnancy, it is ruptured already tube or wherever it is, and size is more than 6 centimeter. Now in this flow chart the same is discussed in this way, that ectopic pregnancy, it is visualized, hemodynamically stable, and assess criteria for the management options, expectant management, and it can be surgical management, follow-up, beta ACG fall, beta ACG rise, then again medical management, more than 15% fall of the beta ACG day 4 to day 7, and then repeat beta ACG weekly until less than 20 international unit per liter. On the other hand, hemodynamically unstable patient, we consider the surgery. Here, the surgical management, it can be laparoscopy or laparotomy, and again, it can be when there is medical management and rise of beta ACG level in day 4 to day 7, and this again it can be surgical management is the option. Then laparoscopy and laparotomy, when we do, it is salpingotomy, which to assess the criteria again, that is we make the hole in the fallopian tube and we milk out the conceptus. And then is the salpingectomy, assess the criteria, and then serum beta ACG follow for persistent trophoblast. Here again we can see that if the medical management we do and there is less than 15% fall of beta ACG day 4 to day 7, again consider the second dose of methotrexate. Serum beta ACG follow-up for persistent trophoblast hit on this way, and here repeat beta ACG weekly until 20 international unit per liter. Anti-D immunoglobulin. Beta negative women with an ectopic pregnancy who are not sensitized to D antigen should be given anti-D immunoglobulin. Fertility after tubal ectopic pregnancy, that is intrauterine pregnancy rate following ectopic pregnancy range between 50 to 70%. Other sites of ectopic pregnancy: cervical pregnancy, that is in the cervix; abdominal pregnancy, it can be everywhere on the omentum, on the intestine, like that; cesarean scar ectopic pregnancy, coronal pregnancy, ovarian pregnancy, heterotopic pregnancy, when there is a tubal pregnancy as well as the gestational sac is also present, that is the second fetus is in the uterus. Then the last is interligamentary pregnancy. Abdominal pregnancy, 1 in 3,000 to 1 in 10,000 types. It can be primary or it can be secondary. That is, there is pregnancy in the fallopian tube or like that, but it expelled out by its peristaltic movement, and then it make its place anywhere in the abdomen. Now you can see this in this picture, the abdominal pregnancy. Uterus is lying beneath the fetus. Diagnosis: laboratory tests. An unexplained increase in the serum alpha fetoprotein value sometimes is found. Sonographic criteria suggestive of an abdominal pregnancy: Number 1, visualization of the fetus separate from the uterus. Number 2, failure to visualize uterine wall between the fetus and the urinary bladder. 3, close approximation of the fetal parts to the maternal abdominal wall. 4, visualization of extrauterine placental tissue. MRI used to confirm abdominal pregnancy following a suspicious sonographic examination. CT, superior to MRI, but its use is limited because of the concern for fetal radiation. Management. Laparotomy. We have to do laparotomy for that. Remove fetus and ligate the umbilical cord close to the placenta without disturbing it. Placental involution can be monitored using serial ultrasonography and ACG concentration level. Ovarian pregnancy. It is 1 in 40,000. You can see here is the ovary and here it is harboring ectopic pregnancy. Seigelberg criteria. What is this? Seigelberg criteria, that is, number 1, the tube on the affected side must be intact. Number 2, the fetal sac must occupy the portion of the ovary. Number 3, the ovary must be connected to the uterus by the ovarian ligament. Number 4, definite ovarian tissue must be found in the sac wall. Management. Systemic methotrexate. Resection of the trophoblast from the ovary and preserving as much ovarian tissue as possible. Salpingo-oophorectomy is rarely necessary in this case. Cervical pregnancy, 1 in 2,500 to 1 in 18,000 is incidence rate. Diagnostic criteria. External os is usually dilated and cervix feels distended or globular. Small uterus on bimanual examination. Curettage of the endometrial cavity reveals no evidence of trophoblastic tissue. For ducts of conception, they are confined within cervix and internal os is closed. On ultrasound, no evidence of intrauterine gestational sac, barrel-shaped cervix and gestational sacs in endocervix. Doppler blood flow around sac. It is the confirmatory sign. Management. It can be conservative, and then next is the suction curettage. Hysterectomy if other interventions fail. Interstitial pregnancy, 1 in 2,500 to 1 in 5,000. Treatment, laparotomy. Simple wedge resection, reconstruction of the uterine wall and salpingectomy. We have to remove the tube. Cornual pregnancy, 1 in 100,000 is its incidence rate. Excision of rudimentary horn and tube on affected side. This is uterus and this is right interstitial ectopic pregnancy. This is laparoscopic view. Again, it is at laparotomy, how it is visible like this. Heterotopic pregnancy, 1 in 30,000. Surgical removal of ectopic pregnancy. After removal of ectopic pregnancy, the intrauterine pregnancy continues in 75% patients. Thank you very much. I hope it will help and increase your knowledge. Jazakallah khairan.